It's good to be here with you today. I want to welcome everyone and add to Terry's introduction. You might like to know that I come to this consulting role after a 29-year career with the federal government. I did work for 23 years with the Social Security Administration at all levels of the disability process, and did work with SSI redeterminations at the beginning of my career. I started with Social Security in 1974. So I have a good feel for the population that you're working with and commend you for the work that you're doing. We really appreciate it. So what's health got to do with transition? Really everything, and we're excited about bringing health as an issue into the transition arena. If you look at this first slide, you'll see the Healthy and Ready to Work website, www.hrtw.org. And we want to caution you, if you do a search for HRTW by itself, you may end up with hormone replacement therapy. You don't want to be there. You want to search for Healthy and Ready to Work or go specifically to our site. The Healthy and Ready to Work initiative began in 1996 to encourage the state Title V children with special health care need programs to put an emphasis on children and youth with special health care needs in transition to adulthood. And the Healthy and Ready to Work National Resource Center, which Dr. White and I are representing today, is a federally funded cooperative agreement housed in the Maine Department of Health and Human Services under the direction of Tony Wall, who's the director of Maine's Children with Special Health Care Needs program. Its goal is to provide leadership, resources, and knowledge to improve health, community participation, productivity, and life for youth in transition. You can learn more about the Healthy and Ready to Work initiative, both past efforts and current activities, at the website. We believe that health impacts all aspects of life. And as you think about it, success in the classroom, the community, on the job, requires that young people are healthy. It's just kind of a common sense thing. And to do that, young people need an increased understanding of their health issues. They need to participate in healthcare decisions and ultimately manage their own health and wellness. Today we're going to be talking about a few things. We're going to start with some definitions. We're then going to look at federal initiatives and mandates and health insurance options. Dr. White will then talk about health and wellness, advice with hindsight or lessons learned from our past activities, and what we call takeaway messages. Let's start with some definitions. First, when we're talking about health, we really mean more than just a payer of services. But in the health arena, the population of young people with disabilities that you know, when we're talking about health, we're talking about wellness, and that young people need to work to maintain their health, to be healthy, and to improve their health status. It's hard to be successful in school or at work if you're having continuous inpatient episodes. And for healthcare services, the idea is that young people should be getting access to healthcare through a medical home, which we're going to talk more about the medical home concept in a few minutes. And also, young people with complex medical conditions especially need care coordination. And then we're going to talk about health insurance. And here we have public and private options for health insurance. And in the public arena, SSI usually is a gateway to Medicaid. And if the young person has worked and becomes entitled to SSDI benefits or Title II Social Security benefits, they can often become eligible for Medicare. And in the private arena, we're talking about family health plans or self-health plans. Working with an SSI population, the Social Security Administration refers to those individuals as disabled. But this same population may be known by other terminology in the different arenas. In the health world, young people are often called children or youth with special health care needs. But in the education world, it may be youth with disability that impacts learning in the IEP field, or youth with health impairment that needs support in the 504 plans. And in the Americans with Disabilities Act and Section 504 of the VR Act, these population may be referred to as having a disability and or a health impairment. So who are children and youth with special health care needs? This is a big definition, but children and youth with special health care needs are those who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition, and who also require health and related services of a type or amount beyond that required by children generally. This is a definition by the Maternal Child Health Bureau, and as you can see, it's a broader definition of a disability than that used by Social Security and SSI. We've also included in this definition section of our presentation some data. The Maternal Child Health Bureau has research that shows nationwide about 13% of children under the age of 18 meet this definition of children and youth with special health care needs. And about almost 1 million of children and youth are receiving services through the state Title V Children with Special Health Care Needs program. And compare that to the SSI population of just over 1 million who are up to age 18 who are receiving SSI benefits. We know that there's overlap between these two populations, but we don't really have a firm number of just how many there are. We've also included the number of SSI recipients who work, and that's a really small number, as you can see on this slide. Youth and young adults under 18, slightly over 3,000 who are reporting earnings, and about 32,000 in the 18 to 21 category, and just under 80,000 in the 22 to 29 category. So let's look at the federal initiatives and mandates, and what we're talking about here are those that include health. First, the President's New Freedom Initiative, which charged the Health Resources and Services Administration and Maternal Child Health Bureau with developing and implementing a community-based service system. And that should include comprehensive family-centered care, affordable insurance, early and continuous screening for special health care needs, and transition services to adulthood. And by those transition services, we mean health-related. Next, the Surgeon General issued a call for action in 2005 to improve the health and wellness of persons with disabilities. And in that call for action, he includes persons with disabilities can lead long, healthy, productive lives. Second, healthcare providers have knowledge and tools to treat the whole person with a disability with dignity. It should promote good health by developing and maintaining healthy lifestyles. And accessible health care and support services would promote independence for persons with disabilities. And these four concepts fit very well with the New Freedom Initiative and what we propose for youth in transition. The next source of revenue or initiative or mandate on the federal side is the state Title V Children with Special Health Care Needs block grant. States receive money in a block grant for health-related programs, including those serving children and youth with special health care needs. A few years back, HRSA started tying the block grant money to performance measures, which we think is a good idea. And there are actually 6 national performance measures tied to children with special health care needs. They are screening, family involvement, the medical home, health insurance, community services, and transition. Each state would set its own numerical or percentage measure, and we're not going to talk about those. You can find those if you go to the state Title V websites. But what we're going to talk about are some of the kinds of things that states are doing in several of these areas in relation to youth in transition. Obviously, the states are doing much more, but here's just a few things, again, in relation to transition. States should be screening children and youth with special health care needs for secondary disabilities, which is significant for many of the SSI population with whom you're working, and can have a tremendous impact on the ability to successfully transition to adult life and work. They're also looking for aging and deterioration issues in these youth. The second performance measure is concerning families, and we know that family involvement is very important to youth in their health issues and in transition. It's important for the youth to have high aspirations, to believe that they can succeed in education and employment and other goals, because we know that these youth want to be just like every other kid. We also believe it's important for families to have high expectations for their young people. They need to believe that their child can be successful in making the transition. And that also goes to educators and mentors and other adults who are around the young people. And then finally, this issue of being healthy, how to stay well for longer periods of time. I told you that we'd come back to the medical home issue, and I want to stress that this concept, we're not talking about a building or a house or a hospital when we talk about medical home. Rather, we're talking about an approach put forth by the American Academy of Pediatrics and the Maternal and Child Health Bureau to provide comprehensive primary care. The states are trying to increase the numbers of children and youth with special health care needs who have access to this medical home approach. For youth with special health care needs in transition, the medical home concept includes the transfer from pediatric to adult health care providers. Actually, a consensus statement was signed a few years ago by representatives of the major medical organizations endorsing this concept. And the real issue here is that the transition would be a natural progression thought out and planned for. Not a surprise all of a sudden at 18, hey, you're not seeing your pediatrician anymore, get out, go to somebody else. So this is an idea that would be thought out. Also, as part of the medical home for youth in transition, it's crucial to have what we call a portable medical summary as a tool to ensure the best medical care, whether that young person is away at school, on the job, or just out and about. The portable medical summary, which you should have as a handout, can be an effective tool when the person needs to provide medical documentation or any kind of emergency situation. It's basically a one-page reference sheet, and it should have all their pertinent information, contact information, a summary of prioritizing their basic health issues, their medications, their treating physician, and it can be used in a number of different instances, whether that person is using it as a communication tool or a learning tool or in an emergency situation. Now, moving on to our next topic, health insurance options. States are measuring the numbers of children and youth with special health care needs who have health insurance, and they're trying to improve these numbers. But we also feel that this is such an important issue that we want to make it its own section in the presentation. And the best thing we can say about health insurance for youth in transition is to plan ahead. While it's fairly common for children to have public or private health insurance, as this slide shows, twice as many adults ages 20 to 29 have no health insurance as those ages 30 to 64. And really, whether or not the individual has a disability, youth are at increased risk for falling into the pit of no insurance. As the slide shows, 2 out of 5 college graduates the first year after graduation don't have health insurance. Half of high school graduates who don't go on to college don't have health insurance. And 40% of all aged 19 to 29 are uninsured during the year. I know that's true from my own children. we believe it's important to prepare for the realities of healthcare funding. When working with youth and families, it's crucial to keep in mind those age milestones. Is a young person going to age out of their family's health insurance plan? If they're covered under Medicaid, will the EPSDT program pay for a certain service or a diagnostic procedure before they reach a certain age? Is that something you can help the family schedule before the young person comes off that program? It's all about timing often. We also know that when young people get their first jobs, whether it's a temporary job or an entry-level job, it may not bring access to health insurance, or if it does, the premium may be too high to make it unaffordable. And then there's the jeopardy of desiring to work and being independent, but possibly losing insurance under a parent's plan or losing SSI benefits, including access to Medicaid. You're probably all well aware that SSI is the gateway to Medicaid and that it's even automatic in all but 11 states. But are you aware that through SSI, through a medical determination by the Social Security Administration, that a person can actually extend entitlement to insurance through COBRA? If the person is found to be disabled under Social Security's definition of disability, they can have an 11-month extension of their COBRA benefits. That's something a lot of people may not be aware of, and even in the Social Security office they may not be aware of it. So you can bring that out, that there is a provision that the person can have a medical determination. They don't need to meet the non-disability factors. They're not applying necessarily for a benefit. But if they're found to be disabled, it can extend the length of access to insurance through COBRA. And then in the public side, in terms of Medicaid, we have a few different situations that the youth can come under. One is if they have been an SSI recipient from childhood, and at age 18 they can go through the redetermination and still qualify and keep their Medicaid coverage. You can also have the situation where the young person has been getting SSI, but at age 18 they either don't pass the redetermination for eligibility as an adult under the adult definition, or the financial qualifications are not met, and they can lose access to Medicaid. And then conversely, you can have the situation where, because of family income and deeming, the child may not have been eligible to Medicaid even though they had the disability, the medical determination part. So at age 18 they can come on as a new recipient and get access to Medicaid at that point. And then in 2005 we have a recent change with the extension of the student earned income exclusion, which may allow some additional individuals under the age of 22 to access SSI and Medicaid who weren't eligible before. So this is a new procedure that you should check out. The link is provided on the slide. And always remember this, SSI is a gateway to Medicaid. And next, private health insurance. Often the best way is for the young person to stay on their parents' plan. And more than 40 states allow an adult disabled dependent child category for health care plans in their states. Many plans also have a student status, and the age eligibility limit varies, but that's always something to check out with the families you're working with. If the young person is still a student, can they stay on their parents' plan? Some states are looking at these issues, and for example, New Jersey is allowing youth to stay on a family plan until age 30, regardless of what the diagnosis is. And ERISA plans can also change age limitations. The youth also have options in terms of paying for health insurance. which may include COBRA. If they're going to come off a plan, they can choose to continue to pay, and COBRA premiums are often quite high, but that is an option. If they're going to college, there may be a student plan available through the college. If they have a job, there may be a group plan available through an employer, and those are often good options because large group plans may not have exclusions or waiting periods that a private plan would have. And then there are self-pay single plans. Again, may or may not be expensive, but another option to explore. And then, of course, the Ticket to Work and Medicaid buy-in where that's appropriate. That's all that I have for you today. I'm going to turn the presentation over to Dr. White, and I look forward to your questions during the chat room. Thank you.
And good afternoon. I'm so pleased to be here and share with you some of the information that we thought would be helpful to you every day as you're working hard with these youth. And as Tom said, we're very appreciative of what you're doing. Now today I'm going to be working and telling you a little bit about health and wellness. And I would like to move right along here and show you a little bit that I really see myself as an ally. I think it's very important that you look to the physicians to help you through this very complicated process with this young person. I see can be helpful to you developing a transition plan around wellness, their disability care, helping them with getting to be productive, and help you to think through some of the insurance issues. I will help you identify medical supports, whether they need them at school, around the campus, and particularly I'm interested in helping you think about emergency and inpatient planning and events if they happen, so that we're not all caught by surprise on this. I want to be helping this young person think beyond their disability, think about being well. I think, as you all know, if we don't feel well, we don't actually do as well as we could. We aren't our best. And you want people to feel well and not be focusing on their health as they're trying to do many other things that you're working with them to become a productive adult. And I want to help you think about accessing for modifications, what the workload ought to be, particularly in their post-secondary education, what equipment and assistive technology would be helpful there. Now, I want to work with you, but I have to remember that with the new laws, when a young person turns 18, there are privacy issues. And this does come up with families as well as people who are very well-meaning, wanting to get access to some of the information. So if you call me, I'm going to say, well, you know, actually the young person may or may not have released for me to speak to you. And I find that hard because people do get angry because they all want to do the right thing here. But we have to remember the privacy laws are extremely tight here under the HIPAA legislation. Now, part of this, I think, is helping people to think about how to give consent. And that's a really hot issue in the medical arena. If they cannot actually sign, people ought to be thinking about getting a signature stamp. This has been extremely helpful, and to think about that beforehand. You want to move the young person in their thought process, how to make an informed decision, going from assent, you know, they're sitting there with the parents are negotiating, or you're talking about things, to actually consent. That means they really know what's going on, and they actually consent to whatever it is that you're talking about, surgery or a new treatment, however you're thinking about this. I think it's important to think about the levels of support as a person is trying to become an informed decision maker. Have somebody who's a health surrogate. I tell people that don't have a disability, you need somebody there to listen to what the medical system is saying to you so that you can think it through later if you need to. There's no pressure necessarily to make decisions right away in many of the instances. And if we're talking about somebody who really people feel perhaps couldn't become a full consenting person, you have to think about guardianship and think about it it can be limited and full. And I think thinking this through, particularly around health, is needed, and we have to think about this as we move forward. Now I want to move on here and think about some of the advice with hindsight. Now, I was involved in a project, the Adolescent Employment Readiness Center, for about 15 years that worked with young people with disabilities and who are on Social Security, and I'd like to sort of share with you some of my thoughts. Also, as I've been both a pediatrician and an internist, as people move from one arena to the other. Now, when you're thinking about it, as you're all sitting there, how many of you are still seeing your pediatrician? Well, I'm sure everybody would say, not me. I'm not seeing a pediatrician. I sure hope you're seeing an internist, though, that you're taking care of your health. But it's interesting that young people with disabilities often are still seeing their pediatrician into their mid-20s and sometimes 30s. And the process, the cultural change of moving from one system to another is quite a shock. Most people without disabilities sort of disappear. They stop seeing their pediatrician, they don't see a doctor for a long time, and then they reappear when they need their health services. But a young person with disabilities needs continuity of care. It's extremely important that they take care of their health throughout this time. So they actually have to make a clear movement from one system to the other. Now, pediatric services, by the nature of them, are family-driven. They're talking to the parents. The young person is sitting there sort of sometimes listening and sometimes not as they plan their health care. The adult provider, due to all sorts of issues around privacy and used to talking directly to the person, is going to be wanting to talk to that young person. As a matter of fact, may not even allow the parents in the room. This is a big shock to everybody. And I want to go through a table here that's coming up a little bit so you can begin to think about this, because most people who are adults take this for granted. But when you're moving from one system to the other, literally one day in one system and in the next day you're in the other system, you have to think about this and plan for it as you're going. So parents and kids find themselves basically between two medical worlds, and sometimes they don't communicate as well as they should. So here is this table. I don't mean for it to be complicated, other than that I think it's helpful to think about the issue, which I have there on the left-hand side, talking about whether the focus, the approach, shared decision-making, and so forth. And then I've contrasted pediatric to adult. And I've highlighted some things that I think it's helpful to help people as they're looking at this issue. What do I need to do to prepare for that adult setting? So the focus now becomes the individual. So as you're preparing, the young person needs to decide what they need to discuss with their physician. Making a list is helpful. Think about shared decision-making. Really, decisions were made by the parent. And you want to start the process of having the young person involved, because the person who's going to make that decision in the adult setting is the person with the illness. The parents necessarily may not make that decision. They can be consulted by the young person, clearly, and they probably should do that. But they're the person that's actually going to sign on that dotted line. And I think that's hard here is a lot of people don't necessarily do what people say they should do. That's non-adherence. You know, you're going to take that medicine? Well, in the pediatric arena, they sort of tolerate it a little bit more. Remember, when you're in the adult arena, the doctor sees themselves as a consultant to you. We think you should take these medications for your ADHD or your seizure disorder. But the person who really is going to do it is the person who gets up every day and has that problem. Nobody's going to be there to check with you. Now, back on the slide there, looking a little bit further, care provision. I think the other thing that's a shock for families is often pediatric systems are interdisciplinary. The clinics run at the same day. You're sort of helped through this process. In the adult arena, you're expected to do it. It's multidisciplinary. You may have to go to the gastroenterologist on a different day than you see the ophthalmologist or the neurologist. That's hard. That means you're taking more time off of work and you have to orchestrate this whole problem. So these things, along with this, that though pediatricians see fewer people with issues that have disabilities, adults see many of them. So the pressure time is much greater in the adult arena. And I think that frustrates people as they move into that area. Now, how about that consensus statement that Tom mentioned earlier? This is a wonderful thing that's available to you as you're beginning to interface with the variety of physicians that you're dealing with. So the largest associations that physicians belong to, the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians, and the American Society of Internal Medicine, boy, that covers about 80% of physicians out there. Their societies have signed on to, I think, a very important consensus statement here. You can see it. We want physicians to understand the rationale for transition, so that family doctor, though they see them their whole life, has to be thinking about these issues, have knowledge and skills to facilitate that process of transition, know if, how, and when that transfer of care is indicated. You have to plan for this. When is it going to actually happen? Don't catch people by surprise. As Tom mentioned, I don't want people to feel kicked out. They have to say, oh, I'm growing up. This is an important thing. It's a natural process. Maintain that up-to-date portable medical summary. I get the young people involved early. Let's do this together if they have that capability. and that written healthcare transition plan by 14. That means we're all thinking about it. That age of majority is 18. Many people transfer their health care at that time because they're going away from home, but sometimes they transfer earlier. What services, who's going to provide them, and how will they be finances? Now let's talk a little bit about the lessons learned. I want to tell you a surprise to me as a physician. I was working with this project. We looked at 12 to 18-year-olds, so I'm looking at younger folks than many of the people you're working with. They had an SSI qualifying diagnosis. Everybody was on SSI, but that wasn't necessarily their active problem. And 40% had other issues for which they're taking medications and need to interface with the healthcare system. That's something you want to think about, because without those medications, they are not going to be successful, even though these medications are not related to the original qualifying diagnosis. As you can see here, asthma, obesity, diabetes, emotional issues, many people are on medications. So if you think to ask, the first thing to ask is, are you on prescription medications? That'll give you the heads up that they need a careful interface with the system. And in our system, we learned that 13-year-olds were more engaged. So those people, when we asked, do you want to be involved, they said yes. 14-year-olds less, 15 and 16-year-olds, not at all. So you have a golden moment to really think about transition around 12 to 13. So that's a really important thing. They're more engaged and they wanted to be involved in the process longer. When we looked at measurements, they had less differences than their age mates without disabilities. That means I had to do less work to keep them on par with the other folks their age as they move through this process. They also made much more significant improvement in all the measurements that we chose to do, questionnaires, when they had started at their age, then we picked them up much later. So I'd like you to think about starting early in this process. What did it turn out for us? If you were for 3 years in our program and started young, you had more education, more paid work experience. You, as the young person involved, thought you had better health. Now, I might look at them and say, gee whiz, I'm not sure their health is that much better, but the youth thought it was. Therefore, they were more engaged and more interested in their health. And they had more likely made the transition in the medical system. Even though we didn't necessarily focus on it, we were trying to help them get into work. So what you're doing is extremely important to help them think about this, and they're more likely to transition into the adult system. Now, what are some of the lessons we learned here? It was a surprise to me that the first thing we did, though we were very focused, as you are, on the job at hand, to get them into the workplace, have them think about their benefits, the first thing you need to think about is, what do they need? And sometimes we found surprising things. They just wanted a pair of glasses because they actually couldn't read anything that you gave them. So asking what their immediate need is, and sometimes it's the health issue. I've run out of my medicines. And so ask what that immediate need is, and if you fill that need, you'll find out that you start off in a much better place, even though it's not where you thought you were going to start in this. Be flexible. Our program actually had advisors. We had a employer advisory board telling us what we should be thinking about. And sometimes we had to change our approach because they were telling us that where we were is not where they wanted them to be when they were coming for that job. Culturally competent. Boy, was it important that we had staff that showed the diversity of the people we were working with. I can't tell you how important that was. It made people more interested in coming. And honor and understand those beliefs. People have certain beliefs, whether it's their religious beliefs or health beliefs or anything about the workplace, that if you understand those and work with them, they're going to be much more interested in working with you in the direction that you're trying to support them towards. Program advisors. I must admit, youth really needed it, and particularly our inner city African American and Hispanic wonderful kids needed some help in how they should be talking to employers. That was a surprise to me. There's a culture here of the workplace that's really very different, and they need to think about that as well as you, I think, should help them think about that. And you become a life coach here, and they look at you that way. As a physician, I often have people inviting me to all sorts of things. When they graduate out of their GED or whatever, I actually never thought about that, but I became a life coach, and you are that to them too, in a variety of things that you never thought you were going to be called on to do. And providing training to understand people's roles. Everybody's role changed. My role changes as a physician, family's role changes, siblings' role changes, and the young person's role change. You need to help everybody know their role is changing. If you just work with the young person and leave the family behind, they'll actually hold that young person back. You need to say, you're going to move parents from being somebody that's doing everything to somebody that's just a consultant. And what is a consultant? You respond when asked. That's a shock to the family, but you need to work with them as they move through that. Building trust, you know that. The number one thing people come to me is, I'm going to lose my benefits. I don't want to get involved. You know this. I want you to let you know that comes to the fore with me too as a physician. Now, on the medical, remember, wellness affects everything. I'm interested in teaching you skills, how to find adult providers, how to manage their health, how to disclose their disability health issues, and how to ask for accommodations. And having you support that as we're working with them is so helpful. As I say, I'm your ally here. So what are our takeaway messages here? I want to remember wellness. What is their baseline? When do they feel best? You ought to know that. Remember health care. You want them to have that primary care to be thinking about wellness. Refer people if they have secondary conditions for help, how to manage it. Be sure they have that protocol medical summary. You have a great tool in front of you. And think about if they have prescription medications, that interfacing with the health system is paramount and a real issue that you need to think about so that we can be sure that people get the kind of medications they need to perform well at the jobs you're asking them to do. Now, on the federal, remember, there are policies and practices that support this. You've heard them all beautifully from Tom. Remember that there's often things on the federal level, on the state level, and as I say, I want to be your ally in this process. Don't forget us as we move forward. I would also like to remind you that there is a Title V, the National Performance Measure, so there is one out there that everybody's focused on, that youth with special health care needs will receive the services necessary to make transitions to all aspects of adult life, including health care, work, and independence. It's there to help these youth move through this process. I want to thank you very much for attending this and remind you that we are looking forward to your questions in the chat room. We are lucky to have Patty Hackett joining us. She's the co-director of the Healthy and Ready to Work National Resource Center, and she'll be in the chat room as well. So we're looking forward to your questions. And at the end of this, there are several slides about resources. Please, I hope you'll look them up. I think they'll be very helpful as you move forward in this process. Thank you so much.